Welcome to Education Without Borders. This episode, we want to have somebody who will tell us about a story about their education journey. This is somebody we have a lot of respect for because he has gone through primary school, he has gone through secondary school, he has gone through a tertiary education, and therefore I will allow him to tell us a little bit more about his education journey or the story, with the highlights of which are the high moments, which are the low moments, and specifically we want him to advise our scholars and our learners. What is it that you'd expect? What is it that you need to watch out against? And what is it that is high, what is low, and how are you able to go through any challenges? Welcome to Education Without Borders.
Thank you very much.
Welcome. So tell us your name.
Yes.
And just take the floor and tell us. Feel free to just tell us. It is free. It has no borders. But we believe that you have a story to tell our young people. Welcome.
Thank you so much. Thank you, Anjiko, the engineer. Thank you so much for welcoming me to this podcast. My name is Johanna Kago Momenya. So, as earlier mentioned, I've gone through primary school, secondary, tertiary education, and I'm even currently furthering my tertiary education with a master's. So, I went to a school called St. Hannah's here in Nairobi, where I did my primary education.
Kenya.
Kenya.
Yes.
And when I did this, the school itself trained me quite well. It was a bit rigorous. It was during the 844. That's when I got my certificate in the year 2000. I passed quite well. And then later from there, I went to a secondary school here in Kenya, in Nairobi, called Strathmore, which gave me a lot of for very good formative years, plus also educating me, where I got my certificate itself. There we got to learn the basics when it comes to your secondary education, as well as making you a better person in total. Then from there, afterwards, I went to a local university here in Nairobi, called in Nairobi University, where I pursued to do my bachelor degree in medicine and surgery. So I got what is called an MBCHB. So it took about 6 years for me to complete that.
Okay,
Yes.
Thank you very much. Let us take a very short break, and we shall now delve into the tertiary education. Let's take a short break. We shall be back.
Okay.
So let us continue with your tertiary education.
Thank you. Thank you so much. The bulk of this conversation here will be mostly on my tertiary school education, which was in Nairobi University, pursuing a degree in medicine. So this degree here is called Bachelor of Medicine and Bachelor of Surgery, of which I later become a medical doctor. So in order for you to do this, there are some prerequisites that are required from your secondary, which are biology, mathematics, chemistry, of course English and Swahili. You need to do those quite well, because the education itself, the training in medical school is very rigorous. It's very tough. There are a lot of very heavy books you need to read and very little time. And when I came from my secondary school, I was getting very high marks. And when I got 80%, 90s, even 75, I find myself very happy. And sometimes a bit sad when I get 70. though that is quite well. But when I entered into university, I found myself, the pass mark there was 50%, and sometimes getting that 50% was very challenging. The education itself requires, especially in you becoming a doctor, to be always right. So studying there is very heavy and rigorous. You find yourself having continuous assessments almost every week, and those continuous assessments lead up to your final exam. And you used to work in quarters. We used to have 4 quarters compared to other university programs that have semesters. So rather than dividing the year into 2 halves, we had 4 quarters, and each one of those used to build up. And the most challenging, I think, that we had was what we call the vivas. A viva was an oral exam. So the education of a doctor is not just someone who is book smart, or you can cram for 1 month and pass, but you're able to bring out that information as asked. So the vivas were very subjective. Nobody got the same questions. So that was a challenge, because in a written exam, all of you get the same questions and you can have past papers to revise. But when you do the viva, it requires you to have a broad knowledge. It requires you to be able to present yourself in a very calm manner. And that one there, especially if you've not experienced it before, is very difficult. So the orals were like that. At the same time, medicine is a very wide subject. It's a very wide subject, and when you're taught these things, you're expected to know a lot of things within a very short period of time. So you find yourself reading continuously, and it sometimes does not show itself in your results. You find yourself working very hard just to find yourself barely making it. You might find yourself doing a supplementary, and supplementaries can be very depressing because you worked very hard but you didn't make it through. I know a number of my colleagues who got supplementaries, and it did affect them very much. And the thing is that we don't usually get a lot of encouragement because it's a bit cutthroat. I know how medical students go through, because they read very hard and they work very hard, but you find out that the results are not commensurate with your hard work. So that can sometimes really affect you and depress you at times. But the best way is to always be resilient. There's something called resilience, where you have different types of people. A fragile person is someone who, if you put some stress on them, they break. A resilient person is a person who can take that stress and actually bounce back. So it's something that I found that is very difficult. You find yourself going through difficult periods that can really push you down. A number of medical students have mental health problems, especially depression. There's a few suicides I knew of, because most of these students came from very top level schools. They are the best. They put their effort in, but the result is not the same. They find out they are being beaten down in university. So people find themselves going into very dark places. So the thing is that the important thing is that everything you do in life, including medicine, not just this can be applied in every field. It's not a question of medicine. Just my perspective. My perspective is that you're meant to be resilient. Life can give you knocks, but you have to bounce back up. Yes. So if I was to give a few examples, more specific, in the first years.
Just before you give us examples, let us pause for a while, so that we can now zoom into those examples. So as we learn, we are getting a lot that you can put in so much, but sometimes you may not get after the exam or the vivas the result expected. I think you would need to tell us, how would one build themselves up so that you have this resilience, and what is it that the examiner would be looking for that the student is not able to actually pick, so that whatever they were taught to read and sit exam and perform in secondary school is not being replicated at the tertiary level. Keep watching. We shall be back in a moment. Let's take a short break. So welcome back. We have so far learned a lot about the experience of the student. You call that the experience of the student. So now we want to ride on the information you have given us. You have given us a background. Now we want to start zooming in into a few points that are interesting. Especially the point you said that there are even cases of top students who come to the medical school, but they end up not necessarily being top. Tell us something very short about that. Why in your opinion, would you think that would be the reason?
Okay, thank you so much. So, when I entered into medical school, you find yourself with the top of the cream. These are people who found themselves in the newspaper, being carried on top, being seen in the village. These are the best of the best of the best. Probably even got a reward from the president or some high-level person. But you enter into medical school, the game is different. There's a lot of self-initiative. The information over there is not congenital. Congenital means you're not born with it. You actually have to sit down and do the work, brick by brick. So when they enter there, sometimes there's a lot of pride in some of them. Because they came from the village or wherever they came from, they were the best. They came sometimes with that same pride that made them assume that they know these things easily. The information sometimes is voluminous. It can be voluminous, meaning that it's a lot. So if you don't actually take your time, some of these students found themselves easily having a cram session that hits 1 month, then they pass the exams. But now in medical school, it's an everyday thing. Practice makes perfect. So you find yourself not just practicing when the exam is there. You should always be ready. You should always be ready.
All right. Yes. At that point, you have talked about in high school is mainly cramming. Apart from the experiments where you go to the laboratory. In medical school, we hear quite a bit about going to the ward. When do you start interacting with the patient? And how does that relate with your studies? Okay. Tell us something about that.
Okay, very good. Thank you. So now, what happens is that you first build the foundations of your medical education with what we call the preclinical sciences. That involves anatomy. It's basically like geography, knowing the lay of the land of the body. Then there's something called physiology, which is basically knowing how the body works. And then biochemistry is required. And then on top of that, you're meant to now know about pathology, how diseases are. Now from there, you enter into the clinical field, whereby you actually now apply that on patients to find out about it. So now, the challenge that comes over there is that it's a very dynamic part of the medical field. You enter into different specialities that have got their own very deep knowledge that you need to understand. So as you go there, every patient is actually a book. And that book over there is to train you as a doctor, first of all, to diagnose the disease. First of all, you have to know what the disease the patient has. You have to know what to investigate. And then after that, you have to know how to treat these patients. So now, the ward work is where you see, if anyone have ever been hospitalized before, if you're in a teaching hospital, usually you see everyone in white lab coats. Not everyone in a white lab coat is necessarily a doctor. So you find yourself with a primary physician who is either a consultant or a medical officer or a resident doctor who is a person training to become a consultant. A consultant is basically the boss. Then from there you have different other adjuvant work cadres that help the doctor to diagnose the patient. So now, as a medical student, you shadow. Shadowing means you're behind the consultant. So now, as the consultant is treating the patient and going forward, you as a medical student are in class. So when you do your ward rounds, the medical student is in class. So the consultant teaches with the patient, and that's what happens. The same thing happens in the clinic. The same thing happens even in the operating theater. The students are there learning through apprenticeship. You don't learn medicine by reading books. You learn by being with patients. So now the challenge comes when you have to know how to diagnose a patient on the drop. You cannot open up a book and start reading what the patient has. You have to have been reading before you came there. You at the same time, you're still learning when you're there. And afterwards, after you've gone and seen those patients, you go back to read. Maybe the challenge occurs that way. Then on top of that, the medical field is actually a very physically involved work. The doctor finds himself, especially with very sick patients, walking up and down, putting in IV lines. Sometimes you can be resuscitating a patient, so it can actually be a very energetic work. So if you combine that with you being a student, sometimes you find yourself overwhelmed. There's an overwhelming part that can occur over there. Because if you're a pure student, you can just sit back into your room, cram, and pass. But when you're actually in the wards, you learn through apprenticeship, through the consultants, through doing things. When I'm with my medical students currently, I actually teach them when I'm in theater. I teach them when I'm in the clinic. I teach them there. So if somebody does not come to the wards, come to the clinic, come to the theater, we'll meet you in your exams. That's the oral exam where you actually need to actually discuss the knowledge that is actually in your head. So the challenge that occurs sometimes to students is that they prefer to run away from their ward rounds, run away and cram, and that's where now we find them, because we find them later in the exams, they have not actually rotated. A rotation is when somebody goes to a different specialty, because we actually teach them the questions that we ask. So the challenge can occur with these top students who are used to cramming. They think that when they cram, they'll pass. But when we actually ask, we have questions we teach them, because when you listen, it actually reinforces memory. When you do, it reinforces memory. Pure reading, you find yourself jumbled up. I've examined a student before who I could tell has the knowledge but has no clinical skills. The person has been cramming but not learning.
That's a good place to take a break, or we'll be coming back to discuss more about that disconnect between a student who is used to just cramming and this other medical student now who needs to even learn more on a real life patient. We shall be back. Before we took a break, you had mentioned something about the disconnect between the student who goes back to their room and crams and seriously reads and then looks at past papers and passes. A conventional student would normally pass after doing that. But you are bringing us to the point where we are now understanding that the medical student needs to be actually rewired afresh to know that there is much more studying that goes on in the ward as they understudy the consultant, as they deal with the real patient. That brings me to my next question. Does this mean then that you cannot really be a very good student on a dummy patient? Do you have electronic, e-medical students where you just go read, you go to the internet, you check? So it has to be hands-on, real life. You see a patient, you can see they're in pain, you see blood, you touch them. Is that what you are
Yes,
saying?
that's what I'm saying.
Please elaborate.
Okay, thank you very much. So you have to understand, becoming a doctor is not like a simulation. You're not going ahead and learning how to drive in a computer game. Patients are very different, vastly different. When you come here and you talk to a patient, you have to, for example, elicit what type of pain they have. Okay? So in the books, you will be told, discuss the pain the patient has. Is it sharp? Is it blunt? Is it aching? Is it throbbing? That's what you read in the book. So you enter, let's say for example, you pass exams, you just pass exams and get out as a doctor. And you never actually interacted with a patient. So now, if you come and talk to a patient, majority of patients don't even understand what sharp is. Majority of patients don't know what aching is. They don't know what blunt is. So you go ahead and you have to talk to a patient. If you meet some patients who don't understand these things, you ask the patient, where do you feel pain? Nasikia uchungu kwa tumbo yangu. So, in medical terms, tumbo means stomach. Okay? So now, if you directly translate that into stomach, you made a vast mistake. What a patient means when he says tumbo, he means the abdomen. The whole area here is called the abdomen. So tumbo is right here. So if you find yourself going direct from books, translating that directly, then you haven't interacted with patients. Tumbo for them could be right here, below. Whereas the stomach is located here. Yeah? So when you meet with a patient, you actually find yourself interacting with them. So let me give you an example of pain. So what sort of pain are you feeling? So I would ask a patient, unasikia uchungu namna gani? Nasikia uchungu tu. That's what they will say. So then you find yourself in the ward having to tease out that description from the patient. Okay, ni kama unadungwa na shindano, unadungwa na kisu ama inawashawasha. So right there, I've shown you the skill of actually eliciting dull pain versus aching pain, because each different pains actually indicate a different disease. You will never get that if you just read your manuals. And how you actually talk to the patient, it's called the clinical history of the patient. You first of all have to establish a rapport. The patient, you say, good morning, how are you? Uko namna gani leo? Uko salama? Yes, I am. Then from there you begin. You will never get that by reading a book. You will get it by talking to the patient and shadowing your consultants, your residents, and even your fellow doctors. You learn this over here. Then the background of your knowledge that you're reading over there will inform you. Yes? So you always have that in the background. You do have classes in medical school. You have classes in the morning. Then you go and apply that. And the real world doesn't exactly turn out the way you want it to turn out. You can read about different diagnoses here and there. But we find out that one patient had a range of symptoms. Symptoms is what the patient says. Symptoms that followed this way, but the signs were different. And the investigations were different. You cannot find, if you do not see that wide range, you'll find yourself as a doctor not able to diagnose a patient, not able to treat the patient.
Oh, that is very interesting. We feel already like we feel inspired that if we went and enrolled to a medical school, now we would enter there with a different perspective. There is this saying also that medical career is a calling, as opposed to, I don't know what the others, the opposite of that one is. What do you understand by the calling? Because from how you are describing, you seem to have a lot of passion and clarity of mind of what this exactly is. What do you understand by that, and what would you like to advise our future or even current medical students?
So that word, a calling, means a vocation. A calling itself means God has asked you to do something. I do not place medical as a calling. I place all good work as a calling. It's a calling to be an engineer. It's a calling to be a lawyer. It's a calling to even be a janitor. It's a calling to be a doctor. I guess the reason why it applies mostly to medical is because we interact with human life in a very intimate fashion, that you can't just switch off your phone and say, I'm off. Okay? Because at some point, a calling is like a calling even to be a mother. You can't take a break being a mother or being a father. The idea of medical being a calling is because of the intimacy in which we deal with patients. at any one time, if I was right now on call, as it were, it means that you can call me 24 hours a day at any one time. If someone gets shot, I have to be there. Yeah. Whereas in other careers, perhaps you switch off your phone. In holidays, you find yourself between midnight, you're sleeping quite well. In medical, you might find yourself not sleeping at all. Perhaps that's where the idea of a calling comes in. But I believe that the word calling applies to all noble human work.
Wow.
From an engineer, a lawyer, even a watchman. Yeah. Any good work that is not stealing or damaging society is a calling. A calling basically means giving your heart out to whatever work you do fully.
All right, that is so good. Maybe we can take a break and then we shall follow along that thought. This is Education Without Borders. We want to know what is expected for a doctor who has graduated, who has gone through internship, who has gone through a medical officer. After that, what we do normal, how is the career progression of a medical doctor?
Thank you very much. So, for the medical students, I think you understand this clearly. But after you graduate, for those who are not medical students, you undergo a one-year internship where you are a doctor, but you're working under an apprenticeship of a consultant. So this here is called internship, whereby you're the decisions that are made. Now you're not a student, you're actually responsible for the patients. So there are different levels within medical field. Once you get your MDCHP, for you to be registered as a doctor, you have to go 1 year of internship. Internship is a very intense time, whereby there's a colloquial term we call interns, hospital donkey, which means that you're the beast of burden. You're there 24 hours a day. There's always an intern over there 24 hours a day. There's no break. It's a 12-month program, very intense, very brutal. But after you finish your internship, you now become a medical officer. So as a medical officer, which now you're called a GP or a general practitioner. So majority of people that you shall meet in the hospital or in a clinic is called a medical officer. This is a general practitioner. He can treat anybody. Almost all, he can treat anything at least on a surface level. Okay? So now within that period of time, you can continue as a GP or you can further education. So you return back to school. But when you return back to school to do your masters, you don't come back as a student, you come back as a worker. So you learn through working. So you choose different specialties. So in medical field, there are different specialties. These specialties are such as surgery, which is a doctor who cuts. You have internal medicine, the doctor who does not cut but treats diseases that don't require surgery. Within that, you also have psychiatry, which is the doctor who treats the mental diseases. Within that, you have an obs-gynae, obstetrics or gynecologists. They call themselves reproductive health specialists. They deal with mothers and delivering babies and things that are specific to do with women. You have now a pediatrician. A pediatrician treats children. Children are not small adults, they are children and they need their own specialists. Within that, you can also go ahead and go into public health. You can become a policy maker who will help this. So within that, when you decide to come back, you do what we call residency. Residency is actually you're a resident. Now, as the intern is the hospital donkey, this is the hospital. When you become a resident, you're the hospital donkey remixed, like now with more responsibility. The resident is the person who is in the hospital who, when you make it to see in a public hospital or even a private hospital, there's most likely you'll see a resident. A resident himself is training to become a consultant in that specific field. It takes an average of 2 years for some of them, and others for up to 7 years. Like to become a neurosurgeon, that's a surgeon for the brain. Ben Carson is one of them. It takes up to 6 to 7 years. Others take 3 years, some take 4, some take 5. So currently I'm doing my residency in Moi University in MTRH in Eldoret. I'm doing it in surgery. Okay, so I'm doing a master's of medicine in surgery, general surgery. So a general surgeon is someone who is a specialist. The word general surgeon.
How long have you been there as a resident, and how much longer do you expect to be there?
I've been there for about 4 years. This is my 4th year. Hopefully, it's a 4.5 year program, bordering 5. So I'll be there for 1.5 years, God willing. I'll be finishing soon. And this specialty itself is called general surgery. And general surgery is a misnomer. It doesn't mean surgeon in general. It doesn't mean a surgeon for you.
I think that is a good place for us to have a break. Okay. We shall now zoom into general surgery. This is Education Without Borders, and you can see we already are learning so much. We feel like we are already in a medical school. We shall be back. We want to listen and learn what is this thing we hear. It's a bit scary because surgery, is it the same as butchery, surgery, or is almost the same?
Okay, that's what I usually find myself being told, na chinja watu. Hapana. Butchery is hacking through. Surgery is respecting anatomical claims to treat disease. We don't hack through people. And what we do is that's why when you begin, you start with your anatomy. You first of all must understand the geography of a place. And then you must understand how to actually go to a certain organ without causing damage. The purpose of a surgeon is the same purpose of any doctor, to treat disease. So we are not here trying to hurt you, we are trying to help you. Okay? It is scary, and surgery itself has a very long history. It started a long time ago. It started in the days of Hippocrates. Yeah, surgeons used to be there in ancient Greece, and how they used to the descriptions of some of the things we used to do are from very long time ago. Now, what we are here currently is called the modern era of surgery. The modern era of surgery occurred with the introduction of anesthesia, which is a drug that makes you sleep. Now allows, because before when people used to come, the surgeon used to have 2 types of doctors. In fact, surgeons never used to be called doctors. They used to be called ministers. The physician used to come through the front door because he's respected, and the surgeon used to come through the back door because when he came, people were screaming. So because they had to hack limbs. So they never even gave us the title of doctor. So even some current surgeons even call themselves ministers because they felt that we were butchers. But with the advent of anesthesia, which is a drug that actually people see, you can actually do your surgery without causing pain. Someone sleeps, and it actually allows you not to. There was a moniker or a saying that the best surgeon is the fastest surgeon. The reason why, because you wanted to cut very quickly before them and be done with yourself. But now you take your time and actually do a good job. So
you are telling us anesthesia is also a specialty.
Yes, anesthesia is a specialty. Okay. So even a doctor who actually takes you to sleep, the surgeon and the anesthesiologist are two careers that are married together. I cannot, without the anesthesiologist, I am just a butcher. Without the surgeon, the anesthesiologist is just a drug dealer. But together, we actually find ourselves working together. So the anesthesiologists actually work as a team. If I was to give it a bit of a popular rendition, you can consider the surgeon in a movie being the movie star. But behind the scenes is a director and a producer who is an anesthesiologist. People might go ahead and say thank you to the surgeon, but behind him there's a big team that actually brought it together. Yes?
Oh, okay. Very nice. We are learning a lot. And I think before you go, what is the parting shot that you would like to tell our learners? Remember, this is Education Without Borders. And now we have gone into the medical classroom. We are in class. What is the parting shot? What is it that you'd want to be? You are student, because I can see you are also now an educationist. What is it you'd want them to take home?
Okay.
Yeah.
So this doesn't need to just apply to medical students. It can apply to anyone. It can apply to an engineering student. It can apply to a lawyer. It can apply to anybody and everybody. You can even apply to myself. The most important thing is for you to have values and virtues. This can be applied in any field. It doesn't need to be medical. It can be even being a janitor. It can be anything. If you have virtues and values, then you'll be a good person. These virtues here are what we call the moral virtues. Because once you apply these moral virtues, you can actually be a successful person in any field you are in. So you have to be prudent. You have to have prudence. That's wisdom. You have to know how to do the right thing at the right time with the right materials. Okay? You have to learn how to acquire these virtues in order for you to apply it in your medical field. For example, it's not prudent for a medical student to laze all the way through and 1 week before the exam is the time they're cramming. That's imprudent. Same thing can apply to anybody. At the same time, you have to have a bit of fortitude, which is courage. You must not be afraid. When I entered into medical school the first year, I remember seeing a cadaver, which is a corpse. And you know, that was the process. Some people have never seen that before, and some people quit immediately. But you see, that is the process of you to learn anatomy in order to treat somebody. I knew a number of students who progressively over every year there was a dropout. The people were dropping out. Some people even finished, graduated, and even never practiced. So you have to have the courage and the fortitude to go forward. Once you learn that, you should also have a bit of temperance. You have to learn to moderate yourself, especially medical students who read too much. You find yourself, you need to relax, but also that relaxation has to be positive leisure. Yeah? If it's destructive leisure, it will lead you down a dark path. Also, there should be justice. The most important thing, all of this said and done, the center of your life should be God. If you don't find God as the center of your life, you can be a brilliant doctor, but you can just be a very rotten person in your heart. I know wonderful, brilliant surgeons, but they do not have a center in their heart, and they don't actually love that. And God is the center of everything. So if you have God as your center, you can find yourself, no matter how tough medical school is, no matter how tough any school that you go to, any field that you're doing, God is the center of all of us. And if you use that, you can have the energy to be the best person you can be. Yes.
Thank you so much. We can never thank you more, because you have really taken us deep into a career that or a profession that is a mystery to all of us, although we know it's very close to the humanity. And we feel very privileged that you are able to come here and spend your time. We know you are very busy, you are a very busy person, but you have that honor of hosting you here on Education Without Borders. And to all of us who are watching, let us learn, especially what he has told us, that you can never be the best you can be without God being at the center of your heart. This is Education Without Borders. Keep learning, keep watching, and we shall keep bringing back this and more similar content. Thank you for watching.